Welcome, everybody. I'm Dr. Priya Gupta for Interventional Mindset, and today I have the one and only Dr. Brandon Ayers, part of the cornea service at Will's Eye, also a dear friend and someone who cares passionately about the ocular surface, whether you want to or not, because we get all these patients, right?
Can't help it. No matter what you do, they're coming our way.
That's right. Brandon, thank you so much for taking time. So today we are going to actually talk about in-office MGD treatments and try to drill down into what patient might do best with which procedure, which Brandon, you and I were just talking about how this is kind of like the special sauce algorithm that
Right.
really is anything but an algorithm. And so, we have access to so many amazing in-office treatments. Today, there's lipoflow thermal pulsation, tear care, iLux, microblepharoexfoliation with BlephX, and intense pulse light therapy. And so we have so many options. Walk me through kind of, how do you decide, how do you stage your patients, and, what are you looking at to help shape that decision?
So we start our diagnosis the same. For me, this is like the corneal ulcer. A corneal ulcer can be a little problem, it can be a huge problem, and you kind of go, "Oh my God, what do I do?" And it's like the ABCs. You're just like, sit back, get some diagnostic tests, do your exam, and the answers will start to come to you as you do the exam. So almost all patients coming through our office, especially when they're usually referred in because of their ocular surface disease. So we don't have to figure it out. We know it's there. We just need to learn how to split it and figure out what treatment protocol is going to work best for them, at least in our opinion. And we're not always right.
Yeah.
So we start with tear diagnostic testing, MMP9 or inflammatory. We do a lot of osmolarity testing. And then most patients will get an imaging of the meibomian glands, my biography, and then a good clinical exam. And the ASCRS algorithm with the LLPP, the look, lift, push, pull, works really, really well. You want to look at the ocular surface with stain. You want to try and see them before they've had proparacaine, or at least proparacaine for a long period of time. Pay special attention to the lids, looking at the contour, look at the meibomian glands, push on them, and see what comes out. Are they all clogged? Is there inspissated oil coming out, or is it more of an olive oil? To your breakup time. And I know this sounds like a enormous amount of work, but it takes about 2 minutes to do, because it's very quick, it's very focused. The diagnostics may take a few minutes to do, but your time in the office putting this all together into a plan that makes sense doesn't really take that much time. But now you've got tests for inflammation. You've evaluated your tear film and how good or ungood the tear quality is. You have your biography, and you've got your corneal staining, and you've also got your patient in front of you. And even the way the patient looks, how the patient approaches you, how old the patient is, it all goes into that special sauce as to what treatments you think are going to work well for them.
Yeah, I completely agree. It's amazing how overwhelming everything you just mentioned can sound, but it's largely driven by staff members gathering data for you. And the time that it takes the clinician to put it all together is really just a few seconds. And, some of those other things, that I look at, I look at, how mobile is my patient? Are they going to actually do treatments at home? Is this a family member that's brought them and maybe I'm only going to see them, once a year because it's going to be impossible for them to come back? And I also look at, what have they tried? Because a lot of times people have come in and they said, "Oh, I had procedure X and it absolutely doesn't work." And you look in and it's because, they have something else going on, like a lid malposition or, something else. And so those, all of those things, and I do want to bring up lid position too, because it does also guide my decision in, which treatment I might choose, because we've all seen the MGD patient with super floppy eyelids,
Mm-hmm.
and the exact opposite, a patient with very tight fissures where inserting something might not be feasible. So
Right.
those are absolutely all things that I take into consideration too.
And one of the last things that I'll look at, and this is something that probably most practitioners wouldn't do, is if I do see a lot of collarettes or a lot of deposits at the lash margin, I will actually pluck a few lashes, and I have lab scopes in my offices, and we'll actually look for Demodex. I don't think that all lid margin disease and ocular surface disease is due to Demodex, but I think some of it is. And we've really seen some remarkable recoveries when we do a more Demodex targeted treatment, which can be combined in many cases with other MGD treatments or procedures. So don't forget Demodex, it is real. And if it's the major problem in your patient, it needs to be addressed.
Absolutely. Brandon, I think it was actually you that made me get a $75 Toys R Us microscope.
I had that scope.
That
Yeah,
is
it took AA batteries.
yes, exact AA batteries. And I still have that puppy to pluck a lash here and there and look under the
I
microscope.
got my first scope at Toys R Us too.
Yes, yeah. I mean, I don't think Toys R Us is open anymore, but
Not anymore. You gotta get it online. Yeah.
you know,
eBay though, it doesn't cost a lot to get a lab scope, and it's certainly been it's worth its money in gold.
absolutely. Now, I mean, one of the ways that I like to kind of categorize some of these patients is by looking at my biography. How do you kind of incorporate my biography? Does it play a more central role when you're trying to assess MGD severity?
It does. So I usually look at the my biography after I've done my clinical assessment. So it really helps to validate and guide my decision as to what kind of treatment modality I'm going to use. Because we'll already know that the patient has blepharitis. I mean, you can see that part on exam, and I've already made some kind of a quality assessment as to the meibomian gland secretions, and also how difficult it is to express those secretions just by pushing on the lid margin. And then I'll look at the meibography and say, yes, we do have something to work on, or we don't have something to work on. You can see dropout, you can see gland dilation, and you can see asymmetry sometimes from the medial to the lateral lid. And you want to know that you have some substrate to work with. Are there any glands at all, or is this a burnt out lid? Because that's going to change for me what treatments I'm going to recommend. For an example, somebody with fairly consistent lid disease along the lid margin, who has relatively easy to express meibomian gland secretions, I think probably will do well with a LipiFlow. We don't need to concentrate on one area of the lid. The secretions aren't very difficult to get out, so I think an automatic heating and expression will work pretty well for that patient. Somebody where I have to really work to open the meibomian glands, I'm not sure that LipiFlow has enough opening pressure or pressure on the lids to get those glands open. And a patient like that, I think I can use a tear care where I'm doing manual expression. I can actually see what it takes, and I can either compress harder or less hard depending on the demand, or work more focally on a certain area of the lid, whereas LipiFlow is just going to kind of do everything everywhere at the same compression force. So that is one of the tools that I really use to help me figure out which modality is going to work best for this patient or that patient.
Absolutely. And I use exactly the same sort of algorithm. And it really is, I think it takes a little bit of time and maybe just a little bit of focal attention to train yourself to, internally grade how well the meibum flows, what its consistency is. And it just takes looking at a lot of lids. Like, we all look at lids, but if you start paying attention to those things, I think it does make a difference. The other kind of category of patients that we haven't talked about. So whenever I see patients with more severe atrophy of the meibomian glands, I actually tend to steer those patients towards IPL as their first option, or even the patients that maybe have like a lot of rosacea plus some atrophy. And the reason is that those patients, they come once a month for 4 treatments. And what happens there is that, they get that repeated expression after each treatment and then the repeated light treatment. And so, all patients want to have sort of that like one procedure that's going to magically cure what's going on for them. Right. But in cases where they're more severe atrophy, I think it is important for us to kind of look at almost like staged procedures. And I certainly have patients where, For example, I might do a series of IPL and then do something like an iLux or tear care or LipiFlow afterwards, to try to initially focus on some of that inflammatory load and then follow up with something that's just much better at relieving obstruction.
So I'm not sure if I ever told you about my first IPL experience.
No?
If anybody out there is using IPL for the first time, do not step on the pedal while you're looking at the light.
Oh,
I thought that I blinded myself like for good. I'm like, oh crap, I'm disabled.
I'm done.
Don't look at it. Make sure you've got the glasses on. But if you ever questioned, is there energy in that light? The answer is absolutely. It is incredibly bright. For me, with IPL, it's a planned, you're going to come back. Now, I think most people routinely do 3 or maybe 4
Yeah.
procedures, as a planned session. And that's probably the right thing to do in a lot of patients. The way that our office works, I'm trying to do something that I can treat it and get long-term effect and not have to bring the patient back. Now, if you're telling me that IPL is the greatest thing ever for ocular surface disease and meibomian gland dysfunction, I mean, I would agree that it certainly plays a role there. Then I would use IPL. But I'm trying to find a system where I can treat once every 6 months or once a year and get a good effect. And maybe I'm looking for something that doesn't exist. And we'll often combine procedures as well. Like I think both tear care and LipiFlow work better if I do some kind of blepharoexfoliation exfoliation before and sometimes a month or 2 after to help keep the effect going. Because almost everybody feels better for a month or so, but I want to get them to 6 months, 9 months, or 12 months before they feel like they need to come back and get another treatment.
I think that's so critical. I mean, our patients, especially now, now we're in COVID times, no one really wants to come back to the office. And um, I think part of, picking the right procedure is actually having that kind of year-long plan. And I couldn't agree with you more about incorporating microblepharoexfoliation with a procedure to relieve the obstruction. So often I do exactly what you said, which is, hey, let's start out with the BlephX. Let's just unroof and debride all the yucky stuff off your lid. And then 4 to 6 months later, let's come back and do LipiFlow, tear care, iLux, whatever procedure we've chosen, and then kind of alternate those, because it's not realistic, I think, for a lot of patients, unless they're in that early stage, mild, very little meibomian gland atrophy. Those are the patients where I agree with you completely. Doing a single procedure can often last, a year or longer. But anybody with that moderate plus disease, setting a plan and having kind of a recurring event of some sort. And I like pairing things that are synergistic, and not necessarily repeating the same mechanism each time. So I'm glad to hear you're doing that too.
Yeah, I mean, I think it's critical. I think we get a better effect when we're doing the main procedure, which for me is usually going to be a LipiFlow or a tear care. And I'll tell patients that this likely is not going to cure them. I mean, we want to set their expectations also. So I'll say, look, the studies show that this is going to work pretty quickly for the majority of patients. And, and I think these procedures play a strong role in that, optimizing the ocular surface prior to cataract surgery or whatever surgery, laser vision correction, contact lens fitting, even just getting a new manifest refraction if you're doing comprehensive eye care, because the studies all show that these procedures work quickly. Within 2 weeks or so, you're seeing some improvement, but they don't always last that long. So telling somebody that this is part of your plan, this may need to be repeated, and bringing that up right up front and saying, look, if you get no effect, we probably will try something different. If you get good effect, but it doesn't last that long, we'll try something to get it to last longer. If you get a great effect, you still may need to repeat this in 6 months. So finding that procedure that the patient can tolerate well, I think is important. And I have some patients who just do not want any kind of occlusion of their eye. They really don't like the on the eye feel of LipiFlow. Others don't mind it, but sometimes the lid fissure is so small, like you mentioned, it's a fight to get it in. you're trying to make this procedure seem like a spa. You're going to like this. You're going to feel better. And you're like using a fellow and two arms in your foot to try and pry this thing in. That's not going to be the procedure for that patient.
Yeah.
Their tear care procedure, or maybe an IPL, is going to be better, where it's just external heat. It's a longer heating period, but they can open their eyes. They can keep the eye open. Not with IPL. They got to
Yeah,
keep
I
their
was
eyes
like,
closed.
you did teach us
Yeah,
that
not
lesson.
IPL. But tear care can be very, very comfortable for a patient. They're not locked into the machine, but the compressions are probably more powerful, and maybe they will or they might not like it. Tear care is also very portable, and I've got 3 or 4 different locations that I go to. It's hard to have 3 or 4 LipiFlows, especially we got LipiFlow kind of at the height of the sale, and it would have broken the bank for us to buy 4 or 5 of them. With TearCare, though, I can actually fit that device in my pocket and take it from office to office. So if I'm seeing a patient at a remote location, they don't want to come into the city. Right now, people are trying to stay out of the city up
Yeah.
here in Philadelphia. So I can say, fine, I can do this at a remote office. I'll just bring the TearCare with me. I can literally put it in my white coat pocket, and we can do a procedure out there. So it's very, very portable, which is nice. And some of the other machines are a little less portable as compared to TearCare. BlephX is also very portable. iLux is portable, although I don't have much experience with the iLux device.
Yeah, we've been pleasantly surprised with iLux, and I couldn't agree with you more about tear care. One of the things that tear care really taught me was, that a one size fits all applicator doesn't really work in all patients. And, we'd have patients come back sometimes saying, I don't know that it really did something. And other patients saying, oh my gosh, you cured my dry eye. And I really do feel like the fit and the stability of the activators, no matter what device you're using, matters, because you have to have good contact of that heating, good heating of the actual glands themselves. And tear care, certainly it's an external applicator, as you mentioned, and then the tailored expression. Similarly with iLux, it's actually placed, this little plate is placed behind the lower lid, and then there's a magnifier where you actually can see what you're expressing while you're simultaneously heating. So, especially for patients that don't have the traditional anatomy, anyone with floppy eyelids, anyone with tight fissures, some of these other procedures might be something to go to first. So I think that, when we look at all of the things here, Brandon, I mean, we've named so many things. We've named anatomical structures, we've named the flow of the oils, social factors, practice factors. One thing we didn't talk about is, can you do said procedure on the fly, right? Can you incorporate it into your practice? And for me, LipiFlow, tear care, iLux, those are easy ones to incorporate into in the middle of a clinic. But things like IPL and BlephX, we've kind of scheduled those on a separate day and parsed it out. Do you do a lot of these procedures on the same day, or?
So it's tough to say. We used to, but now our office flow is so regimented because we have to get the patients in and out. It's more difficult because now, like today, I was an hour behind, and that used to be, I'm always an hour behind, but now it's a major issue and someone's going to call the cops because there's 5 people in my waiting room, So I'm less likely to do on the fly, but sometimes that patient comes in who's traveled 3 hours.
Yeah.
We have the time, and it's better for me to get it done now and not bring the patient back versus have another office visit later. So it kind of goes both ways, and it depends on where I'm at in my office schedule. For me, I don't have IPL, but tear care is quite straightforward because my technicians do almost all of the prep work. I just come in and spend about 5 minutes doing the expression. So it doesn't really take that much of my time. LipiFlow is the same thing. I usually actually set the patient up for the LipiFlow and hit the go button. But then for about 14 minutes or so, I'm pretty much finished until it's done. So it doesn't really take that much of the clinician's time to get them done. So in the right setting, we will do them on the fly. It just depends on the day and where we're at in the office flow.
Well, there you have it, you guys. There's so many options out there. Look at my Biography, look at the lid anatomy, look at how the oils are flowing. And my best advice to everybody, and Brandon, I'm sure you'd agree, is just try things, see how it works. And if it's
Yeah.
not working, adapt and change. And I think no matter what, a key message here is that you should pick a procedure to treat MGD and integrate it into your practice, whether it's in your pre-surgical patients or your, referral base for symptomatic MGD.
Yep. I agree. You got to try procedures. You got to keep your patients engaged and make them feel like they're part of the decision-making process. And if you do that, there's no such thing as a failure. Your patients are involved and they'll say, hey, it did work, it didn't work, and they'll guide your treatment. But I appreciate anybody who's even trying. So pick your
Absolutely.
favorite procedure and get started with it.
Couldn't agree more, Brandon. Thank you so much, Brandon, for joining us today on our podcast. Always a pleasure to talk to you, and I always learn something new from you.
Thanks, Priya. Nice talking to you.
Take care.